virtual research rounds. When we would do virtual research rounds in the theater at the IWK, it always felt so empty, even when we had, 20 or 25 people there. There's just so many seats. But with the virtual research rounds, I love seeing the numbers. I almost feel like we get more people attending the virtual rounds than the live research rounds. So it's really quite nice.
Great. We sure saw that with the Department of Emergency Medicine. We went to a virtual research series, and we get people from Cape Breton and PEI all logging in all over New Brunswick, who couldn't always make the day to come down. So
yeah, it's great.
So.
Jill, could I just ask you, when you're kind of giving the housekeeping notes, to just mention that this session is being recorded? Just to let the attendees know that it's being recorded, and if that it's just part of our privacy policy to do that.
Okay.
Thank you.
And I will also stress, so this stuff is just being accepted for publication. So there's an embargo, so no screenshots or sharing or anything like that. I've promised that to the PIs on this one.
Okay, perfect. Excellent. Well, at 12:03, I think we'll probably get started. So just a reminder, and I'm sure everybody has heard Kim and Jason give those little housekeeping notes. But just to reiterate, we are recording this session, just so you know, for your own privacy reasons, as well as if you have to leave, this will be made available for you to come back to if you need to. From Jason's perspective, we ask that no screenshots are taken of this research yet. And yeah, that would be great if you refrain from doing that. Please keep your microphones muted. I am pretty sure that Kim has sort of control over all of that on her end. And at the end of Jason's talk, I will field questions if you want to use the hands up option in Teams. But right now, I am going to pass it over to Dr. Jeannie Shoveler to introduce our speaker for this month.
Thanks very much, Jill, and welcome everyone to IWK Research Rounds. A special welcome to our presenter today, Dr. Jason Emsley. Dr. Emsley is an assistant professor within the Department of Emergency Medicine, as well as a staff emergency physician at the IWK and the QE2, as well as IWK Pediatric Trauma Team Leader. Thank you so much, Jason, for taking time out of your busy agenda in all those various functions to join us today. Your research that focuses on how our understanding of neural development can be applied to repairing central nervous systems in traumas, in case of serious trauma, various neurodegenerative disorders, is groundbreaking. And the pediatric trauma epidemiology and departmental flow work that you're doing really reflect the clinical impacts of the research areas that you are so actively engaged in. And certainly COVID, the pandemic, has absolutely provided an opportunity to engage in the kinds of multi-site research that you engage in and lead. And we're delighted today to hear from you about some of your latest work around a nationwide study that's been assessing the impact of the pandemic on patient volumes, acuity, and outcomes in the pediatric emergency department context. So thank you and welcome. Absolutely delighted to have you with us today.
Great. Well, thanks very much for your introduction, Dr. Shoveler, and thanks to you and to Jill Hatchett and Kim Farmer and everybody at the research offices for inviting me to present. I've been really looking forward to this one and being able to present on behalf of my colleagues on this one as the site PI from the IWK. So again, many thanks to all the research support that we get through the IWK and through the Dal Department of Emergency Medicine, and then a big shout out to the fellows and students, nurses, all working on pediatric trauma, because I'll be touching on some of that as well through this talk. I may not take the full hour, but certainly happy to take as many questions as folks have, and always happy to take those questions in the hallway, IWK style too, the way things often happen too. So the work that we're doing is part of the PERC, the Pediatric Emergency Research Canada Network, which is a fantastic group of people across Canada, so various site PIs, so we can do larger pediatric studies. And I especially want to thank the two lead PIs for this nationally have been Yaron Finkelstein at Sick Kids and Stephen Friedman at Alberta Children's Hospital, whom I'm sure many of you are familiar with. Just a great overall group of people to work with. And these are all the site PIs from our network all the way across Canada, 11 different sites. But I especially want to mention my colleagues here at the IWK, Eleanor Fitzpatrick and Katrina Hurley, who have been instrumental in helping me establish stuff as a researcher at the IWK, and who have participated fully in this project too. So big thanks to Eleanor and Katrina for this. So before I take you along down this road here, in general, I just want to tell you the overall goal of this study was to look at how does COVID affect children. In many ways, I'll be talking about things almost in the context of the second victim study, in that the acuity for kids or how ill kids get from COVID obviously is very different from your morbidly obese 78-year-old with CHF. But in many ways, the effects on kids are peripheral. And any of us who have kids, or obviously we're all seeing kids regularly in our practices, we know that there are all these other effects on children. So that's what this study really sought to learn. What's the effect of COVID on children through the emergency department lens? And what we found is that COVID has had, in various phases of it, huge effects on visit numbers, acuity, hospitalization. We'll be talking a bit about mortality, and as well as these other effects on pediatric trauma and as well as pediatric mental health. So it's affecting a whole variety of things that we're all seeing, and I'm sure any of us could come up with anecdotes about how we've seen COVID have an effect in our practice, in our daily lives. So I'm sure many of you are familiar with this, the Johns Hopkins coronavirus dashboard, which probably a year ago I was looking at obsessively and have now tried to block on my browser because the numbers are changing so much. I dropped the screenshot of this slide in about 2 weeks ago, but then I actually I updated it just a couple days ago, and it's remarkable the number of changes that we obviously are seeing. So we're talking about something that's constantly occurring. So we're just trying to take some snapshots in time. And this is the Canadian situation, at least as of May 1st, where we've had about 1.2 million cases, about 24,000 deaths, and the Nova Scotia numbers are obviously they'll be updated through the day today. But what's especially interesting here to me as well is, and this is all Public Health Agency of Canada data, who we're also doing some surveillance projects with. But if you look at the top in the cases by age here, we see that kids actually, or anyone under 19, makes up about 20% of the actual cases. But certainly they're not making up as much of the mortality, but I'll still argue that in many ways they're making up a lot of the victim load, if you will, from COVID. And especially here, when we look at deaths by age, and then these are numbers from about a week and a half ago off the PHEC website, we have relatively few pediatric deaths, but obviously when we get up into the 70 and above age range, we're starting to see significantly more deaths. Again, now with all the variants, this is going to be changing as we'll start to see more deaths in the younger populations, especially the, say, around the 30 to 50 age range. So what do we know so far from adult studies? And there have been some good adult studies, and I'll just summarize them right now. We've seen in general about a 42% drop. This is from a US study in just emergency department visits, just by numbers, during the pandemic. We've seen an increase, though, too, in people who are coming in sicker. So people with more delayed presentations for myocardial infarctions. We're seeing from some smaller studies increases in deaths from out-of-hospital cardiac arrests, people reluctant to call more difficulties with transport, with getting that PPE on. So more people are just dying out in the field, and many of them are people we probably could have potentially saved. In addition, we're seeing also delayed presentation of strokes in adults, or if they're delayed, if they eventually get there, obviously then time is brain, and so the stroke burden is much higher. We're seeing more severe presentations of DKA in adults, and as well huge amounts of the psychiatric burden in adults as well, with all the stress that we see. And I certainly, I and my colleagues at the QE2 are certainly seeing a lot of problems with mood disorders, anxiety disorders, worsening psychosis. But what do we know from pediatric studies? And there have been a number of smaller studies, but most of these have really been single institution or single region studies, or looking at specific diagnoses like the effect of COVID on asthma presentations, for example. But what we do know is that from a small US study, there's been a 50 to 59% increase in high acuity visits to emergency departments, more presentations for fever and infectious illnesses. And a small UK study identified 9 pediatric deaths associated with delayed presentation. So it's not just the adults with the heart attacks, it's also kids coming in too late. So how we wanted to go over this, these are our methods here. So looking across the country, we had 11 sites here, going from BC Children's Hospital all the way up to us here at the IWK. So 11 sites participated and provided data to this. And just take you through the time frame that we're looking at here. So we're looking at, down the left here, we're looking at 3 years, the year of the pandemic, although that will continue on for us, obviously, and then the 2 preceding years to have some comparisons. And we looked at this block here from January 1st to April 30th. So we picked a 1 quarter section of the year, rather, time frame to look at the effects of COVID on pediatric presentations. So we're just going to zoom in on this and look at the January to April portion of all these years. And so that's just blown up here for you. And then you'll see we divided into the pre-COVID, early COVID, and pandemic COVID periods, just with the green, the orange, and the red respectively. And the reason we did that was just to watch in time through these time series analyses how things change with presentations. And we picked these times because to go from pre to early, that was when Canada had its first confirmed case. And then pandemic was the day of the WHO declaration, where we all probably knew where we were standing when we heard that declaration. So again, I'm going to keep coming back to this to talk about this pre, early, and pandemic COVID period. So our data sources, things were extracted from our EMRs, and so big thanks to our decision support services here at IWK for helping us with that. And we looked at aggregate site level data, and age was put into 1-year categories. And our data analysts across the country, and then the people who actually did some of the analysis at sick kids, were blinded to what they were looking for. And we had several outcomes, and we'll talk about these as we go through, but our primary outcome was quite straightforward, the number of visits per week. Our secondary outcomes were things like acuity, hospitalization, ICU admission, length of stay if a kid went upstairs, and as well as death. Excuse me. We had a couple of exploratory outcomes, trauma-related visits, as well as mental health-related visits. And when we get to the statistical analysis, the first thing that I want to say is I am not a statistician. I'm a bench scientist, and I'm interested in epidemiology, interested in trauma studies, but I am not a statistician. So if people have deep statistical questions, I can certainly put you into touch with the people who did all our deep statistical analyses. What I can say is that we made all our decisions what we wanted to look at a priority, and we made this broad underlying assumption of an existing data trajectory. So without this virus, things would have continued along roughly the same track. Kids would have gotten about as sick from other things as normal. So we're comparing them to those expected baseline trends. In the bottom right, we have a picture of a plague from an earlier time. And for those of you as a public service who are not really interested in the deep statistical analysis and quasi-Poisson methods, I have a number of pictures of the plague that could keep you entertained while we go through this. So our analysis for our primary outcome, so that's ED visits, is we did an interrupted time series analysis. So basically just looking across those time frames. We that was to keep into account different timing for public health interventions. Obviously, what we did in Nova Scotia was different from what Manitoba did. What the IWK did was different from what the Stollery did. We modeled these aggregate effects by inclusion of a level change from baseline. So again, that's comparing things to what we would normally expect to happen. For our secondary outcomes, such as acuity or hospitalization, we used quasi-Poisson regression models to measure change events per week. So what's the change in acuity over a week's time? We used binomial regression for proportions and other regression models for the length of stay data. And we tried to account for seasonal and secular trends. Similarly, with our trauma and mental health, those exploratory outcomes, we stratified children by age less than 10 and greater than 10. And again, we use those regression models to measure change events per week, to look at proportions, and to account for those seasonal and secular trends. We set our p-values for two-sided tests of significance. We set the significance at p less than 0.05, and this was all done using the R project for statistical computing. Again, if you have statistical questions, I'm happy to field them or try to get the answers for you on that. And if you want to talk about the plague paintings, I'm happy to do that as well. So what did we find out? Again, looking at this early, and pandemic COVID period, we had a total of just over 577,000, so over 500,000 children we looked at through these time periods. And just along for each year, rather, we had a couple 100,000 for the 2018 and 19, and about 159,000 visits for 2020. So looking at 500,000 kids off around this whole time frame. The median age was about 4.5. There was no change across the years as far as those who identified as male who were presenting to emergency departments across the country. So our first information we found out about ED visits is that sites all had these massive decreases. So if you look across, you look at your various favorite children's hospitals, and I've marked off here our favorite, the IWK. We can see in the pre and the early periods, we saw about 757 and 926 visits through that period of time, and then dropping down to about 318. And obviously during that time, that was when we were shutting down clinics, setting up different zones within the emergency department itself. But if you put this all together, we looked at trend lines for mean weekly number of ED presentations. So these are the lines, kind of a busy slide though, of all the different sites. But putting that all together, there was no change in presentations in pre and early pandemic. So things weren't hitting people as far as not coming to the emergency department. So there was really no change. And you'll see with all these slides, I've put down the confidence intervals, et cetera, and the p-values for those who are keenly interested in that. So no change in the number of kids showing up in pre and early pandemic period. But we saw that visit numbers significantly decreased versus pre-pandemic. So we had a 58% drop nationally in the number of visits during the pandemic period, or this pandemic period that we were looking at. And that negative 58% there, that drop, is pretty similar to what was seen in some of those smaller US studies that I mentioned. So we have fewer kids coming, but what does all that mean? So we looked at acuity. And we used, for those who aren't super familiar with this, we used the standardly accepted pediatric CTAS acuity scale. So the level 1 patients, those are resuscitations. So that's obviously an active status epilepticus. This is a cardiac arrest. This is a major trauma. So obviously all hands on deck, we're seeing that kid right away. A level 2 case, see within 15 minutes, that would be a pretty acute asthma exacerbation, for example. A level 3 would be, say, a 3-year-old with a fever, a little bit tachycardic, vomiting a lot. You want to see that kid quite soon. Level 4s would be your standard, say, fever, runny nose, vitals are good, but certainly would benefit from some medical attention. And the level 5s are the non-urgent, say somebody coming in just to ask a question about where to get toenails clipped, for example. So very typically not necessarily needs to be seen in an emergency department. So we use this pediatric CTAS acuity scale to look at how this virus has affected acuity. And what we found then, if we look by CTAS level, that the proportion of CTAS 1 visits did not change. So that's of the overall number of kids. So taking into account we've got fewer kids coming, but of the proportion of those. So we found the proportion of CTAS 1 visits didn't change, meaning that if there were still cardiac arrests, there's still major traumas, those are still showing up and in the typical proportions that you would expect year to year. But what we did see that CTAS 2 visits, these are our sick asthmatics, for example, or our kids pushing sepsis, the febrile infant, the febrile 3-month-old infant, for a 3-day-old infant, for example. CTAS visits increased, CTAS 2 visits increased during the pandemic as a proportion of sites. So our sicker kids are coming in more. There's more proportion, rather, of kids being sicker. Whereas, say, our CTAS 5 visits, the very non-acute stuff, actually decreased during the pandemic. So people were probably making the decision, and we'll get to the discussion more later, making the decision not to come in for these less exciting things. But what did it do to hospitalization? And obviously, my colleagues up on PMU and ICU can talk about how their numbers changed locally. But broadly across the country, the number of hospitalizations themselves decreased during the pandemic by about 41% here. Not surprising, we have fewer kids coming in, so probably that's going to bring down the number who are being hospitalized. However, though, when they come in, the proportion of children that are hospitalized did increase during the pandemic. So with an odds ratio of 1.39, suggesting here that yes, kids are coming in, but they're more like, if they are being admitted, if they're sick, they're more likely to get admitted, or suggesting that these are sicker kids. Similarly, with ICU admissions, in particular, the number of actual admissions to the ICU across the country, again, over 500,000 kids, there was about a 50% or 49% drop in the number of admissions during the pandemic. However, again, just like hospitalization to more like PMU, the proportion of ICU admissions increased during the pandemic. So we've got kids who are, though fewer kids are coming in, a greater proportion of those are being admitted, and significantly of those who would go to ICU, there would be a greater proportion of those going up to the intensive care. So sicker, more likely to come in overall. When it comes to the amount of time kids spent in hospital, there was actually no change in hospital length of stay. So once they went up there was really no difference. And if we just look across these numbers here, and I've just summarized them at the bottom for the 3 years, yes, 2020, the pandemic period, the number looks smaller, but it's not statistically significant. So I won't fall into that trap and say there was a trend for that. And just suffice to say that there was really no change in how long kids stayed in hospital once they actually went upstairs from the emergency department. With mortality, again, we know that mortality is quite low with children, but there are a number of other complications. And again, this is all pre-variant stuff. There was no change in mortality across the country per 10,000 visits. Significance was 0.82. So though the numbers look like they may be, quote, slightly trended down in 2020, that is not statistically significant. So again, no change in mortality across the country. When it comes to ED revisits, so our classic revisit, say, would be coming back for IV antibiotics, or say the child who the fever hasn't gone away in a day or two and parents getting more worried, or they're not holding stuff down if they have gastroenteritis. These are our ED revisits within about a 72-hour period is how we set it across the country. These can be kids who may or may not need to come back. Obviously, those who come back, the kid who has, say, periumbilical pain, we say, well, come back if it goes to the right lower quadrant and your girl gets sicker. So obviously looking for appendicitis. But when we look at ED revisits across the country, those revisits within 72 hours significantly decreased during the pandemic. So there's a 55% drop in revisits. So parents less likely to bring their child back for a recheck of something, or possibly if the child was getting sicker. But overall, the proportion of that of the ED revisits decreased. So what we're seeing, when I just go back to this slide here, when they decreased during the pandemic, they're essentially ganging on to the overall decrease in number of patients presenting. So fewer patients presenting in the first place and fewer patients re-presenting because of the pandemic. So I just want to move on to talk about trauma and some of the things that we saw there as some of our exploratory outcomes. What we found, and this is, we're looking at the trauma visits for 0 to 10 years of age per week for all sites. And we found that trauma visits significantly decreased during the pandemic for younger children as compared to the pre and the early pandemic period. So there was a 37% drop in actual trauma visits for kids. Again, not surprising, we've got fewer patients coming in, but it does mean that there's less trauma presenting to the emergency department, which in some ways is worrisome to me, because what also happened with the 0 to 10, the younger, from infants up to 10 years old, the actual proportion of trauma visits increased during the pandemic with an odds ratio of 1.51. So what's happening is trauma is making up a larger proportion of those kids coming in as a chief complaint. So there's more trauma happening and being brought into the emergency department relative to other things bringing kids into the department. When we look at older kids, so 10 to 18 years of age, what we found was that trauma visits overall, again, decreased during the pandemic for older children. They decreased by 73%, which is a significant drop in trauma visits compared to the pre and the early pandemic periods. But unlike with our less than 10-year-olds, the proportion of those visits for older kids decreased during the pandemic. So meaning, yes, fewer older kids are coming in for trauma, but trauma is making up a much less sizable portion of the actual visits to the emergency department. So with an odds ratio of 0.65. So fewer of them are coming, and of those who come, they make up a much smaller proportion. And I'll talk a bit about why I think all these factors are as we get through to the discussion in a bit. What effect did it have on mental health? And I know that we all have anecdotes or things that we're seeing within our own departments, and I'm sure my colleagues in psychiatry and EMAS can say a lot more about this as well. But what were those initial effects on mental health in what we saw nationally in the first 4 months of the global pandemic? Overall, and again, just like trauma, we've divided this into less than 10 and over 10 years old. There was no change in the proportion of mental health visits for all ages. So if mental health is making up X% of all visits to the emergency department, it really didn't change during the pandemic. But what we did find, though, and again, this is the kind of decrease that we saw with overall patient numbers, mental health visits decreased for all ages during the pandemic. So those visits, so there were 60% fewer kids coming who were less than 10 for mental health stuff, and a reduction of 56% of 10 to 18-year-olds who were coming during the pandemic. Again, like other presentations, if you say, well, these are presentations, say, for rashes or something, it's one thing to have a decrease in visits for all ages for maybe certain things that may go away on their own. But with mental health visits, this is significantly concerning to all of us. And we're starting to see the effects of this with a drop of almost 60% across the board for mental health visits. So, and as I said, I'd probably get through this a little bit quicker than an hour, but happy to take questions. So just get to some discussion stuff here. So overall, again, what's the effect of COVID on kids? And we saw it significantly affected the number of visits, so the decreased numbers of visits across the country, that it's affected acuity in that we're seeing sicker kids coming in as a proportion, and then kids who are very not sick, not coming. We're seeing decreases in the number of kids getting hospitalized, but if they are coming in and getting there's a higher percentage that were getting hospitalized during this early period and the mid period of the pandemic. Thankfully, there's no change in mortality, at least with what we saw at this point. But again, as I mentioned, we're actively involved in a COVID surveillance program with the Public Health Agency of Canada. So those numbers are still pouring in now with all the variants. We also saw huge effects on trauma. So we're seeing increased, very worrisomely, We're seeing increased proportion of trauma in younger kids, but then also a decreased proportion of trauma in older ones, and then significant effects on mental health. So some thoughts about some of these findings. There are some general limitations, obviously, to this study. It's a large study, which that's kind of nice, but it's really hard to elucidate local differences. This doesn't tell us exactly what happened at the IWK or at Alberta Children's, for example. So it's hard to really pull out what happened within each department and how they reacted to it. Another limitation is this was all pediatric EDs from the PERC network. So this isn't saying what's happening at Dartmouth or somewhere in Sudbury, for example. This is only places within that PERC network. Although I should say that there seems to be more of a relative push for people to bring their kids to the pediatric tertiary care hospital if they can during the pandemic versus going to a community hospital. That seems to be a bit of a trend that we're seeing with some smaller studies and some anecdotal stuff. And obviously with this study, we can't assess the motivations. We're not asking, why did you stay away? Or why did you keep away for so long, even though your kid was getting sicker? Or why did you decide maybe just to wait and follow up with the family doctor online? We obviously also looked at a snapshot in time. The pandemic is ongoing, obviously, and there are fluctuating effects. Some people start to be more likely to want to come now to the emergency department. We're certainly seeing surges in the adult emergency departments across the country, and the variants have obviously changed things. And then some of the things this pandemic has had an effect on in those early times that I gave you data for are really now having their effect that we're seeing, what I'm calling the mental health tsunami that we're seeing through the emergency departments. So specifically with visits and acuity, we're getting that decrease in visits despite all the primary care closures. I and others were speculating, well, with all the family doctors shut, we're just going to get more kids coming in for low acuity stuff, but that really wasn't the case. And we saw this increase in severity or acuity of children, and it was likely due to deferral or deterioration of that kid, that parents might have put it off for just that much longer, even 12 hours, 24 hours longer. There's certainly studies, for example, in adults showing higher numbers of perforated appendices, appendicitis versus in the past pre-pandemic. And I think that the acuity is also the fact that we're getting sicker kids coming in also is reflected in that increased proportion of admissions, more likely to get admitted. But what are some opportunities? What are some things we can learn from this? And this is where I think we can all have a great discussion coming from different departments and different roles within the hospital. We can provide public reassurance, and certainly Dr. Katrina Hurley has tried to do this locally to try to tell parents the IWK is a safe place. If you need to be here, please come here. We have PPE, we have things in place. It's safer to come here than to go to many other places in the community. So to tell people it's okay to come. This is also causes us to reflect on our ED priorities. How are those patients who aren't acute, maybe they never should have been coming in the first place, and how could we improve access to family doctors? We also saw, and I know I can say this anecdotally, some sicker kids coming in with chronic diseases, where parents were holding off trying to do it all on their own. So it all behooves all of us to check in regularly with our chronic patients and give us opportunities to enhance virtual visits to help support the family doctors out there, pediatricians doing virtual visits, and then some ideas about some virtual assessments that can be done for potential emergency patients through EHS. So there's certainly some opportunities that can come out of the COVID crisis, no matter how much we hate it. When it comes to trauma, as I mentioned, that we have an increased proportion in younger children. And why is that? I think part of it is maybe at home now there was less supervision. There was not the supervision that they were having at school, at least for the school age one. We certainly saw more falls and burns. So this could be parents distracted. All of a sudden, family life is just thrown upside down. Though our study didn't look at it, there's a lot of anecdotal evidence that there's an increase in non-accidental trauma. This, unfortunately, is not surprising. You have families under massive stress, there's unemployment, there's caregiver burnout, Everybody is trying to deal with things economically, and these are all things that can be huge factors in increasing the non-accidental trauma rates. And I mentioned we also saw a decreased proportion of trauma presentations and proportion in older children. And I would speculate, my team members would speculate, that that's probably because there are fewer organized sports, so harder to go out there and play soccer and get an ankle fracture. Fewer people are on the road, fewer teens out on the road, so there's less drunk driving or texting and driving, which texting actually has now surpassed alcohol as a cause of collisions for younger people. And there's also, for some of our slightly older teens, fewer workplace injuries for them. So that would probably explain a little bit of the changes for the older kids. But what are our opportunities there to try to reduce trauma for children? The first really is to make home life better, is to support our essential workers, the ones who have to get out to their jobs in the food service industry or help us all at grocery stores. How can we make things less stressful for them at home? How can we make it so that they're not stuck leaving their kids unattended? And this goes also for providing resources for the caregivers who have lost employment. We need to make sure, and we can advocate for pediatric health in many ways, that there should be good employment benefits, or unemployment benefits rather. And we need to support those caregivers who work from home. How can we help them with distraction? How can we make sure that employers are supporting that? And recognize, as I mentioned, the risks of non-accidental trauma that are increasing. And finally, just finished here talking about mental health. I mentioned earlier, we showed that there's been a decrease for all ages of a 56 to 60% drop in mental health visits. And this all happened despite reduced access to other resources. So those kids may not necessarily be able to get an appointment with their outpatient psychologist or care team. They may not be able to obviously meet with their counselor at school, or even to connect necessarily with people who provide them with a lot of support through their mental health issues. And I think part of it sort of felt like the start of a war. In the early part, there was this early resilience of this massive shared social stress. So this idea of, well, we can hang on. Of course you're feeling bad. Of course you may be having more anxiety. There's a pandemic on, but there was something brewing there, I think, with mental health for children and teens that we're only really seeing now. And probably one other reason that we had these lower presentations for mental health, or I would speculate, is that families were also focused on their own stressors. The parents themselves are worried about themselves. They're worried about their parents getting sick, their own kids getting sick. And then things that are brewing inside that teen's mind are sometimes fall by the wayside while we focus on other things. But then again, like with trauma, there are opportunities. And these are, I would say that we need to provide emotional support again, and to teach and model resilience. Parents need to tell their kids that things are going to be okay, even sometimes when we're not sure that they will be. We need to recognize that there are also a lot of limitations, and I've certainly heard this from kids coming in to see our EMAS colleagues, that remote appointments just don't feel the same as sitting across from somebody who can help to work kids through things. And obviously an opportunity, but things we need to prepare for is preparing for medium and long-term implications. I think we're going to see the effects of the virus on mental health. We're seeing it now, and we're going to see it for years to come. So this gives us all opportunities, things that we can do within our pediatrician offices, within the Department of Psychiatry, and just in the community as a whole. So again, I hope I've shown you that COVID has had a huge effect on numbers, acuity, hospitalizations, trauma, and mental health. And it provides us a lot of opportunities for things that we all can do to help kids through the rest of this pandemic. These are all the references that are cited by our paper, which I'm happy to say was accepted yesterday. So we're looking forward to seeing that out in print. And if anybody wants to receive references, I'll be able to pass those along in due time. And just to finish up, a big thank you to having me come and talk here. It's been great to be able to share this. And thanks to all the site PIs across the country, and I'm sure many of you recognize names of some good friends across this slide. And as well, again, big shout out to my colleagues here, Eleanor Fitzpatrick and Katrina Hurley. Jennifer Bennett from Decision Support Services provided the turnaround time from Decision Support Services for this data. They're faster than Amazon Prime, so thank you very much. and again to the PIs at Calgary and Toronto's Stephen and Yaron and Perk overall, and then all our colleagues with emergency medicine and our trauma team and within the IWK. So with that, thank you very much for having me, and I'm happy to take any questions.
Jason, I'm going to start. That was really spectacular and certainly interesting. One of the things that I found particularly interesting, and I know you didn't do an analysis or even look into the decision-making processes of the parents and or caregivers. I think that would be a fascinating study 2, 3, 4, or whatever, because I think there's a bunch of different ways that this study can branch out, investigating different aspects of the findings that you guys landed on. But what I found particularly interesting, you know, we've tried so hard as a province to keep unnecessary cases out of the emergency department, whether it's pediatric cases or adult cases, and encouraging people to use 811. And it took a pandemic to get your CTAS 5s out of the emergency department. And then, you know, you talked about the increased presentation of your CTAS 2s, especially with asthma, which shows that parents were very informed on the catastrophe that a COVID infection could have on a kid with chronic asthma. So there's those two pieces demonstrate to me that there's very clear decision-making processes going on with the parents. And I think it would be really interesting to break that down and have a look at what those processes were during the pandemic. I do have a couple of questions here on the sidebar. I'm not sure if your mental health slide there towards the end actually answered Dr. Sinclair's question, but Doug asks if there's any update on delayed presentation of mental health patients to the ED.
So what I can say is some stuff from adult studies are certainly showing we're getting patients whose psychosis is certainly worse. There's a huge amount of medication non-compliance, so patients not coming in, say, for depot administration of things. As far as the overall severity of presentations among pediatrics, all I've heard is more anecdotal stuff from colleagues across the country that we're certainly getting more presentations, representations of kids, and that they're certainly seeing more kids showing up with this all started with COVID for kids. But as far as the, I think these studies should, I'm sure others are looking at this right now. We didn't look at this, but I think it would be really helpful to look at how are we seeing a higher rate of overall suicide, like serious suicide attempts? Are we seeing worse psychosis, more intractable things, more things related, say, to drug or cannabis use, for example? But I don't know if I've answered Dr. Sinclair's question here, but I think things are certainly going to be worse with the presentations, and I think we'll have increased severity and numbers, and I think we probably will, I'll speculate that for the next 1 to 3 years. I'm not sure if that completely answers it, so certainly let me know if you want to follow up on that one, Dr. Sinclair.
Thanks, Jason. No, that sounds very good. Thank you.
Our second question for you, Jason, is from Dr. Cheveler, and Jeannie asks, any thoughts on whether these patterns of presentation at the ED might also vary across population subgroups? So, for example, socioeconomic strata, maybe rural versus urban. Yeah, those different types of populations.
Yeah, so that's a great question. We obviously didn't look at that, and I don't know if we could really parse that out from the data set that we have. I do know that, so this is all pre-COVID stuff. We do know that there are differences in presentation and sometimes with acuity, and we see this with trauma of urban versus rural populations, people without the resources to necessarily get to a tertiary care center, or who may, if you've got a family, say they may have limited resources for kids, no childcare, they may put off coming longer. I would say that, and again, this is me just bridging the anecdotes and the facts that I know, that this pandemic has been, if we as health professionals living in wonderful Canada are all suffering. People who have very limited economic resources are suffering even more. It's shown just how much it's shown the discrepancies in healthcare in general. It's exacerbated those. Mm-hmm. So I would speculate that the worsening acuity, delayed presentations, worsened trauma, worse mental health effects would probably be reflected by people with more challenged socioeconomic status.
Awesome, thank you. I will open it up to the rest of our attendees. If you have any questions, you can either raise your hand with the little raise your hand icon, or you can plop something into our conversation, and I can ask your question for you.
Sure. And just while people are asking those too, I just wanted to touch on that. You mentioned about the kids who, do they need to or not need to be there? And it's always a tough thing, because that perception, I'm sure Dr. Curran could talk about this better than I could, but that perception of why somebody needs to be there, what drew them in. And I should say, with the CTAS-5, there are certainly CTAS-5 cases that are, well, my child saw a tick on a walk, should we come in? It's kind of like, okay, that's very easy. But sometimes people come in that the acuity may be low, but the problem may be high, and they may actually be coming in with a cloaked complaint, in that what's really going on is that they don't have formula, for example. So their vitals may be fine, but the vitals of the home life aren't fine. Mm-hmm.
Okay, I'm not seeing any additional questions. Okay. And no hands raised. So I will thank you here, Dr. Emsley. That was a really, really great presentation. It's really interesting to see how things have fluctuated across the 3 different time frames that you looked at. I will tell everybody else, if you do have any questions that you think of later, I'm sure Dr. Emsley will be more than happy to answer them for you via email. This is recorded if you want to let your colleagues and peers know, and this will be up on the research website, within a day or so. And other than that, I would tell you all to keep your eyes peeled for our June virtual research rounds, which will be coming up the first week of June. And with that, I will end it there. Thank you very much, everyone.
Great. Thank you.
Thank you.
Bye-bye.